Yes.
I will introduce Dr. Pandolfino, and the question is the future of esophageal diagnostics in the endoscopy suite? My bias is no.
And my bias is yes.
Okay.
All right, well, thank you very much for that opening. Don't put me in a defensive posture here, but I was asked to discuss what the future of esophagology is and whether or not it would be in the endoscopy suite. And I will tell you that in my practice, the more and more I've taken care of these patients, the more and more I've realized that endoscopy, as we currently utilize it, has been a missed opportunity. These are my disclosures or declarations. So, you know, when we see patients in clinic and we hear their esophageal symptoms, you know, our diagnostic approach has always started in the endoscopy unit, essentially, after we get a good history and physical. And I consider myself a pretty good clinician. You know, I'll see the patient, I'll ask them questions, I'll watch them eat. And then typically, regardless of whether they have heartburn, regurgitation, dysphagia, chest pain, or food impaction, I may have a little bit of an idea that this may be eosinophilic esophagitis, maybe a mechanical obstruction, or potentially an esophageal motility disorder. But the bottom line is my differential is pretty vast, and all roads lead to endoscopy at that particular point. Because I want to rule out a mechanical obstruction or a severe inflammatory process, or EOE, before I even consider motility testing. And of course, if I do see a negative test, then certainly we will be thinking about a differential that will include NERD, motility disorder, or a functional process, which we know now will be a DGBI. And if you look at the Rome-4 diagnostic algorithm just for dysphagia, and this is just an example because every single one of the algorithms that you will see that is dealing with the esophagus always starts out with an endoscopy, ruling out a significant obstruction or a significant inflammatory disorder. Now, in addition, when you're doing this endoscopy, there's also a lot of important information that you're going to glean from that. You know, if there is esophagitis, you're going to grade it appropriately using the Los Angeles classification. And if you're not seeing esophagitis, or even if you are seeing esophagitis, you will look at the flap valve, the Hill flap valve, in order to ascertain whether or not this is a mechanical process that's driving this, especially when you're looking at significant hiatus hernia. So it's extremely important to do this. Now, an often overlooked attribute of endoscopy is that you can actually get pretty good information regarding whether or not this is also a motility disorder. And that was actually defined many years ago by Alan Cameron when he actually did endoscopy and could pretty accurately define whether or not these patients had achalasia. And he would look at contents in the esophageal lumen, the anatomy, whether there was significant dilatation. He would assess the tightness of the lower esophageal sphincter using his tactile reference during the endoscopy. And just recently, we worked together with the Baylor group, and you could actually put together a pretty good clinical impression of motility based on the upper endoscopy, using a scoring system looking at esophageal contents, anatomy, motility, whether or not they had non-peptic esophagitis, and then, of course, the resistance through the esophagogastric junction. And we found that this would work with pretty good sensitivity and specificity. Not perfect, but at least give you a pre-test probability, which, you know, in many cases could be very confident they had a significant dilatation, contents, and resistance at the EGJ, that this person had achalasia or an esophageal motility disorder. Similarly, you know, you could see if someone was truly normal and had a patulous EGJ and had a very low likelihood of having achalasia. So when I see these patients in clinic, you know, I typically perform my endoscopy. I look for inflammation, I look for stricture, mechanical obstruction, EOE, and a significant hiatus hernia. And if that is normal or I don't find an obvious cause, then these are the patients that I will see in follow-up and send for further esophageal function testing. And that could be either motility testing with manometry or the addition of 24-hour pH impedance. Now, I've always been a big fan of manometry and, you know, had made the conversion to esophageal pressure topography in 2003 when I met Ray Klaus, and really have put a lot of effort into this technology. And I love this technology. I think it's a great technology that can allow us to better define motility disorders. But, I'm harking back to the fact that, no single technology is perfect. It doesn't matter whether you're looking at esophagram, endoscopy, manometry, pH impedance, wireless catheter, catheterless pH monitoring. They all have some deficiency that can be made up by complementary testing. Now, the one thing, though, that I did learn, and I'm pretty confident of, people hate manometry. Patients do not like it. Trying to get them to come back for a repeat manometry after an intervention is very difficult. We lose a lot of people to follow-up. And not only is it difficult to get patients to come back, many are traumatized by those particular procedures. They're not pleasant. So I've asked a lot of questions of the audience here. How many people in the audience have had a manometry? Okay, so there's a good portion of people who haven't. Okay. How many people have had more than 8 manometries for research studies? I always do them first on myself because I never want to recruit somebody unless I've experienced what they've experienced.
Doing the same thing over and over again is insanity.
Well, it's with combinations, balloons, it's different things. But the bottom line is that they're very difficult. They're very difficult to perform, and we know our patients don't like it. So what if we had the opportunity, when the patient comes in, I initially see them in clinic, they have these symptoms, I elicit this, and I say, you're going to need an endoscopy. They come in for the endoscopy, and instead of 50% of the time telling them, I have no idea what's going on, and I'm going to have to send you for very uncomfortable tests later on, what if I could, at the end of that endoscopy, rule out a significant major motility disorder, and also rule out significant gastroesophageal reflux disease? I will have essentially been able to rule out almost everything in our differential in the span of maybe an hour, or if I had to do some wireless pH testing, 96 hours. And at the end of that period of time, I would have answered all of their questions. To me, that's an opportunity that we shouldn't discount. I mean, number one, better comfort for the patient. Number two, efficiency of diagnosis. I mean, these patients sometimes wait 3 to 6 months to get their diagnosis. How many times do we see a patient finally come back 7 or 8 months later with the diagnosis of a disorder of gut-brain interaction and tried on multiple medical therapies and finally get reflux testing and be told that they're normal? I mean, so why would we not take this opportunity to effectively and efficiently diagnose our patients? So we have some opportunities here. And I've been working on balloon technology in the esophagus for a very long time, since 2001. Started out using barostats, very difficult. Had to use fluoroscopy and keep my foot on the pedal. It was a lot of radiation exposure. Then finally developed something called the hydrostat, which was a rhinographin-filled balloon. Similar, I had to use fluoroscopy. And I was toiling with this process, and we had some IP around this for distensibility testing and geometry testing of the esophagus. And then a small company who was working with Barry McMahon and Hans Gregerson developed the functional lumen imaging probe, which was similar to the hydrostat, but I didn't have to sit there and do fluoroscopy and create these balloons. So of course I threw out the hydrostat and jumped all in on the flip, because now I had a commercialized tool that could do everything that the hydrostat did, but much easier and without me getting exposed to radiation. So we played with this tool for a while, and it was interesting because when we first started playing with this, the thing I was most interested in with this device was studying eosinophilic esophagitis and studying the fibrosis and the restrictions that would occur related to fibrosis in EOE. And it was interesting because I would look at these tracings, once again going back to tracings, I still love tracings, and these are tracings of diameter changes. And what I would see over and over were these patterns. And here were the pressure signatures, and these look like peristaltic waves. So I asked my programmer, I said, a la Ray Klaus, let's convert those diameters to color. And we used the same process that Ray did. And what we saw was this beautiful peristaltic response, especially in asymptomatic controls. 95% of people have this beautiful repetitive antegrade contraction, which is probably a normal defense mechanism, akin to secondary peristalsis, a little bit different because the balloon is through the entire esophagus and sustained. But nonetheless, we saw this pattern. And to me, as someone who loves esophageal physiology, see if I can get this to run here. It doesn't look like it's going to run. Well, I think you can appreciate this was a thing of beauty. It was so sequenced and timed, and we would see it over and over at a rate of around 6 per minute. And it would synchronize with the crural contraction. And as I mentioned, we saw this in almost 100%, 95% of our asymptomatic controls. So we decided that maybe we should look more into this. And as I mentioned, it made sense that this could be a correlate for manometric or motility function of the esophagus. Because despite the fact that primary peristalsis and secondary peristalsis have a different trigger, they still utilize the same neuromyogenic architecture to generate that peristaltic sequence. They're not the same, but once you trigger it, they're pretty similar. There's not that huge a difference between those. There might be a little bit difference in the deglutitive relaxation versus the descending inhibition that you might see. But when we looked at this and we went back and saw how many of these patients who had racks had either normal or a non-specific borderline motility, it was almost all of them. So right then and there, this became a very nice surrogate for normal motility. If you see racks, you can almost be guaranteed that their neuromyogenic function is intact, right? So this is a different stimulus, but once again, that same common denominator of the balance between excitation and inhibition and that neuromuscular function. What we also started to see as we studied these patients was that there were different patterns that were pretty unique. So if patients had a spastic motor disorder or a type 3 achalasia pattern on high-resolution manometry, when we did flip, we would see these contractions that occurred at a rate of 12 per minute. And they were also sequenced with respiration. So once again, we started to think to ourselves, well, what is this? Well, there's lack of nitric oxide, lack of that latency period. So these would be firing at the same rate. And to be honest, we haven't proven this yet, but it seems like a big coincidence that the respiratory center that governs quiet respiration sits right in the brainstem on top of the dorsal motor neurons and fires at 12 per minute. Now, why in a normal person is this only firing at 6 per minute? Well, because the refractory period in a normal esophagus usually takes about 10 seconds. So there were a lot of things that intrigued us about this beautiful physiologic response. And remember, it's different than primary peristalsis. This is a stress test to the esophagus. It's almost like having a food impaction sitting there and looking at how the esophagus will respond to a food bolus or volumetric distension, maybe from a large reflux event or regurgitant event. So we started to play around with this and started thinking about, well, what can this device do? Well, it can do a lot of different things. It could assess peristalsis by triggering a secondary peristaltic-like event. It could definitely assess EGJ opening dynamics, because that's what we were actually originally looking at in achalasia and looking at post-myotomy treatment. It can provide an excellent estimate of esophageal stiffness in EOE and potentially guide esophageal surgery. So when we started to look at this, there were distinct patterns that had pathologic relevance. So once again, the rack pattern here, I think you can't see the, do we have a pointer?
Is it working?
No, it's not working. No, the mouse doesn't show anything. It's okay. So in the top left up here, you see the rack pattern. You see another pattern with some antegrade contractions that are borderline. You can, oh, I think you're turning, yeah, sorry. No, that's fine. And then you can see these patterns where there's no contractions. We could even see scleroderma esophagus, where they would have absent contractile response and a wide open EGJ, just like in a hypotensive LES. And then we would see these curious spastic-like patterns that really defied normal peristalsis, or what we would assume to be a normal response. That were, what we call sustained occluding contraction, LES lifts, different patterns, but definitely something that was abnormal. And as I mentioned, where we first started with this process was really focusing on the EGJ. And this was a really beautiful tool to assess whether or not your pneumatic dilation or your myotomy was adequate. And in fact, there are multiple papers now that support the relevance of using this intraoperatively. Whether it's Ian Cook's paper in pneumatic dilation, and I do all my pneumatics with this device, or multiple studies now that show its utilization in myotomy. And when you start to look at high-resolution manometry correlates with these patients who have simultaneous flip, they look very similar. It's not so hard to imagine that this is a normal peristaltic primary peristalsis, and this is what their flip would look like, these beautiful antegrade contractions. Similarly, achalasia with their EGJ opening not occurring and absent contractile response. So we started to compare this to high-resolution manometry. And when we looked at EGJ opening dynamics, we could clearly see that the EGJ DI and the maximal diameter during the distension protocol tracked quite well with IRP in both the supine and upright position in terms of predicting bolus retention. In fact, it behaved or performed just a little bit better, but not anything to be jumping up and down, but it's certainly not worse. So we started to conceptualize, well, can we look at this in the context of the Chicago classification? So what does flip look like when we look at high resolution manometry on top and the functional luminary imaging probe on the bottom? And there clearly are these patterns that you can look at, and once again, a picture's worth 1,000 tracings. I learned that. And I've also learned that, you cannot ignore the patterns. These are very easy. And I will tell you, we already created an AI platform on this, which works quite well because these are just heat maps. And AI loves heat maps. So you can clearly see that these patterns here are certainly helpful. What we started to see also was that if you started to look at patients with scleroderma, for instance, and you started to look at the correlates between their high-resolution manometry and their functional luminary imaging probe and their panometry patterns, we could see that if you looked at the scleroderma patients who were doing well, we see these patients, they have scleroderma esophagus, but they have no heartburn, no dysphagia. But then there are these other patients with scleroderma esophagus who have horrific reflux, and they have significant aspiration and pulmonary complications. And what we found in a very small series was that if they had some degree of intact antegrade contractions, those patients tended to do better than the ones who had an essentially dead esophagus, which meant they had abnormal primary and abnormal secondary peristalsis. So in my practice currently, and this is how I practice, the patients come in with whatever esophageal symptom it is. I watch them eat, but invariably they're going to get an endoscopy. I do their endoscopy. I rule out those problems that we talked about, and if it's negative, I assess their peristaltic pattern, that contractile response, and their EGJ opening, and I essentially lump them into these groups. And this is how I treat them. So if they have normal motility, those are patients I may either do mucosal integrity on or put a wireless capsule. If it's weak, meaning that they have absent contractile response, but they have a wide open EGJ, they probably have reflux. I'll study them for reflux. If they have a mechanical obstruction, I will tell you, this helps us pick up. There are mechanical obstructions that are missed all the time that we pick up on flip because they have a 14 or 15 millimeter stricture at the EGJ, often missed. So we don't do empiric dilation anymore. We actually do targeted dilation because we know there's an abnormality. And if they have a non-spastic obstruction, meaning they have absent contractile response and their distensibility is very low, and I scope them and I see that they have a dilated esophagus, why would I put that person through a manometry when I'm pretty sure they have achalasia from just the endoscopy and I've just confirmed it with a physiologic test? Now, if they have a spastic disorder, I'm not exactly sure what that is. That could be jackhammer, it could be spasm, it could be type 3 achalasia, it could be normal. Those are the patients that I will refer for high-resolution manometry. So if I'm not exactly sure what's going on, that's what we'll do. Taking this one step further, we just had this paper accepted for publication in gastroenterology. These are actually the patterns that you would see in eosinophilic esophagitis. And what's interesting here is that if you break the patients up into two categories based on normal distensibility in the body versus abnormal distensibility in the body, and then further separate it out by contractile response, you can do a much better job of predicting treatment response in terms of eosinophilic esophagitis treatments. So for instance, if you have normal distensibility, the response rate to PPIs is 70 to 80%. Now remember, all comers who get a PPI with EOE is about a 30 to 50% response. Well, now you can get that up to 70%. In addition, if you have abnormal distensibility and a reduced contractile response, these patients never respond to PPI. They're a completely different phenotype. So you can save these patients the whole process of getting another endoscopy 8 weeks after PPI because they're not going to respond. And you can start them on topical steroids or a biologic right away. And once again, expedite their care. Save them an extra endoscopy and the discomfort of having to go through that. Now, there's other things we can do during endoscopy. So say, for instance, we go through this and I find a flip that looks like it's borderline contractile response, maybe a little bit weak. Well, now I can do some reflux testing. So at that particular junction, during that same endoscopy, I can place a wireless capsule and study that patient for 96 hours. And in doing that, I can pretty comfortably, off medication, decide whether or not this patient has reflux, yes or no. And this was a study we published and was a triple-blinded study where we had multiple people involved in the interpretation. And what we found was that it could actually, this particular process could predict pretty confidently who can stop a PPI, and then also who's probably going to need chronic maintenance therapy with a PPI, who has true chronic GERD that will require maintenance therapy, whether it's PPI or endoscopic or surgical therapy. So we felt pretty comfortable with that. And now we have a platform where we can assess these patients during that index endoscopy as to whether or not they have reflux disease. Well, what about mucosal integrity? Well, this technology has been around for quite a while. I don't want to steal too much of Prakash's thunder, so I'm not going to. But theoretically, if you could assess mucosal permeability and design a test that could screen for reflux, yes or no, or whether or not I even need to do a wireless capsule or further reflux testing, and if you could define whether that is normal, that would have a lot of advantage. And this technology, through various iterations, whether it was a catheter-based, a balloon-based, there definitely is a signal there where you can see that there is this point where you could potentially segregate out people with normal impedance and not have to send patients for reflux testing, whether it's a wireless capsule or a catheter-based study. And as I mentioned, this has now evolved into an endocap, which seems to be a lot easier to use, and once again, can be done during that index endoscopy. So I think that we have enough evidence now that we can garner and gather a ton of information and take that opportunity during that index endoscopy to really give the patient the answer that they're searching for. How many times have you gone to a patient after you've scoped them and they're looking at you for the answer to their questions and you're like, I didn't find anything? The disappointment in their faces. They want to know what's going on. They don't want to wait another month or 2 months or 6 months. They want the answer. So in my perfect world, I think this should all be done automated and through that initial endoscopy. And I think there's a lot of opportunity here. We have very, very good PROs and quality of life measures, and we've got AI now that can synthesize that and give you a pretest probability of what they think is going on. You can combine that with an AI platform focused on the esophagus and that endoscopy that can also inform and give you a pretest probability. That could be fed into another AI platform that you garner from Flip, which will tell you then what the next step is. And then depending on which you're working up or the pretest probability of reflux, you can go right to mucosal integrity or wireless capsule, and then feed that into an in silico virtual esophagus model that will then tell you exactly what operation or medication that particular patient needs. So the future of esophagology is in the endoscopy suite. May not be today, but it will happen. And once again, you cannot ignore progress. So with that, I will leave this for my partner in crime, Prakash.
Thank you, John, for actually finishing before time, as you promised. And we're taking questions in the end, so please hold all the questions that you have. And of course, post-dinner is a little drowsy, but let's listen to some impedance, and then we can take the questions. Okay. So the next talk is going to be by Prakash Gyawali, a very close friend, and most people here know him. So he's going to talk about esophageal mucosal impedance from research to clinical practice.
Thank you, Shobana. So she was trying to characterize this as a flip and a flop. So I'm the flop, and I'm probably truly the flop because I'm going to try and put what John put in 3 slides into 30 slides. So let's see how I do, because he's given my talk already. So yeah. I know, you did. So I'm going to try and give you the basis for using mucosal impedance, mucosal integrity, in evaluating research and where it can function, where it does not function. So the start is the understanding that the squamous epithelial cells in the esophagus are normally tightly adhered to each other through cell adhesion structures. And in the context of different types of injury, different types of luminal noxious agents, or sometimes even psychological stress or other kinds of injury, these cells tend to separate, right? So you can see in the prickle layer that there is space in between. And Daniel was actually part of some of these original studies where he demonstrated using electron microscopy that you can actually see this separation in the form of dilated intercellular spaces. And you can see here at baseline, no separation. With acid and bile, and weakly acid, you see that the spaces are separated. And indeed, these can be measured, right? And this was a study. Again, Daniel was part of this, 92 patients, 10 healthy controls, where these dilated intracellular spaces were measured and correlated with impedance. That's how impedance comes into the picture, correlated with impedance. Why impedance? Because when there is injury, when there is damage to the mucosa of the esophagus, the transmission of an electrical current has less resistance. So the lower the resistance, the lower the impedance. And that's where impedance comes in. And if you look at these GERD phenotypes, you can see here the intercellular space diameter being wider in the reflux phenotypes as compared to normal, and the same pattern of impedance being lower in these GERD phenotypes compared to normal. Now, the correlation between acid burden and baseline impedance is better than the correlation, both are negative, by the way, the correlation between baseline impedance and the diameter between these intercellular spaces, partly because acid is not the only noxious agent. Other noxious agents can also do this. Now, another model for dilated intracellular space is other types of esophageal inflammation, like eosinophilia. In eosinophilic esophagitis. You can't see the impedance trace at the top very well, but this is a histopath slide from a patient with marked eosinophilia and dilated intercellular space, and the mucosal impedance you can see there is below 500 ohms. Here's another patient, modest eosinophilia, still with dilated intracellular spaces. And here the baseline impedance is around 500 ohms, less eosinophilia, less inflammation. And this is a treated patient where the eosinophilia is gone and there is no dilated intracellular spaces. And here the impedance is somewhere around 3,000 ohms. All right? So again, the more inflamed the mucosa, the lower the baseline impedance. And what do we mean by baseline impedance? Impedance measured in the distal esophagus when there is no bolus and no artifact in the vicinity. And you can actually see that in pathological reflux, baseline impedance is much lower than in physiologic reflux and in healthy controls, and negatively correlates with acid exposure time. So how is it traditionally measured? The original description of mean nocturnal baseline impedance involved measuring the baseline impedance in the middle of the night when there are no artifacts, 3 10-minute periods between 1 and 3 a.m. And this is one of those 3 10-minute periods at the 3 centimeter level as well as the 5 centimeter level. So here you can see that the values are in the 3,000 range, no GERD. And this is a patient with reflux, with presumed reflux-related injury. You can see that the baseline impedance here is below 1,000. Now, there is another way of doing it, and that is to take the entire supine period and averaging that. And that value actually correlates very well with the mean nocturnal baseline impedance. And this was termed simple MNBI by Daniel. So this was a study that was done by Daniel's group. Now, the original Italian group that reported mean nocturnal baseline impedance tried to define a threshold, a cutoff threshold. They came up with 2292 ohms, and this was based on patients with PPI responsive heartburn, not really true non-erosive reflux disease, because at that time we did not have the requirement for pH test to be abnormal to diagnose non-erosive reflux disease. This was based on PPI response. And you can see in this cohort where they came up with that 2292 ohms, that the patients with erosive reflux disease had lower values than non-erosive reflux disease and healthy controls. The healthy controls had values close to 3,000 ohms. This was part of a normative study that was undertaken by Daniel, getting data from healthy volunteers studied in different motility labs around the world. I don't know why my colors are a little off here, but the lower value here, the bottom end of the whisker here, is the 5th percentile values. And you'll have to take my word for this, but this is around 1,500 ohms. So the healthy individuals can have values as low as 1,500 ohms, which brings into question whether that 2292 is truly a cutoff, a true threshold that segregates normal from abnormal. And if you look at some of the more recent studies that have been published, here you see the study that was published in 2022 by the Italian group, where in patients, these are all patients with normal acid exposure time had values around 2,100 ohms, and patients with abnormal acid burden above 6% had values closer to 1,000. And in that same study, healthy controls had values close to 3,000 ohms. So there is clearly a range of baseline impedance values. But it is fair to say that using mean nocturnal baseline impedance, you can actually phenotype these different reflux syndromes, whether that be refractory reflux or healed reflux, non-erosive reflux disease, or functional heartburn. Now, when you compare erosive disease to functional heartburn, mean nocturnal baseline impedance performs very well, but you don't need that. Erosive reflux disease, you can see on endoscopy. Non-erosive reflux disease, the performance characteristics are a little less robust, with area under the curve of around 0.67. And that's because of the heterogeneity of that group. Now, it is clear that mean nocturnal baseline impedance is a surrogate for acid exposure time. And in this study that we did, there was clear prediction by distal mean nocturnal baseline impedance in outcome from treatment of reflux, both on univariate and multivariate assessments. Right? So where can you use nocturnal baseline impedance? Not necessarily when the acid exposure time is abnormal, because it's a correlate, but where acid exposure time is equivocal. If you look at mean nocturnal baseline impedance and look at outcome, what we found was that when the mean nocturnal baseline impedance was low, the response resembled patients with acid exposure time of more than 6. So low mean nocturnal baseline impedance and inconclusive AET resembled AET more than 6 in terms of response to anti-reflux therapy, and the opposite with when the mean nocturnal baseline impedance was normal, and that resembled patients with non-reflux etiologies. So baseline impedance may help further define the gray area within AET thresholds. Now, baseline impedance does more than that. So it's higher, it's lower when there is a hiatus hernia. And when there is motor abnormalities of the esophagus. What's more interesting is in the presence of bile, when you do bile monitoring. And it turns out that the patients with hiatus hernia, if you do bile monitoring, those patients who have a lower mean nocturnal baseline impedance have a higher likelihood of having bile in their refluxate. And that was shown very nicely by this correlation from Nicola's group, Nicola Di Bortoli's group. So other elements in the refluxate, other than acid, may contribute to that low nocturnal baseline impedance, not just acid, but other components. And another point to make is that after you treat reflux, so if you get rid of the elevated reflux burden in the esophagus, baseline impedance normalizes. So here you can see in the table endoscopic fundoplication. You can't see my arrow, but the top row here, pre and post, you can see at 6 months time point after fundoplication, after PPI therapy, the values go up as the mucosa heals. And here you can see that in PPI non-responders, the value tends to remain low in contrast to responders. All right, so baseline impedance improves with successful treatment of reflux disease. And in studies on PPI, when you do pH impedance on PPI, the finding of nocturnal baseline impedance less than 1500 in conjunction with an elevated acid exposure time or elevated reflux burden predicts response to surgical management. So in other words, if the baseline impedance remains low, it implies that there continues to be some noxious element bathing the distal esophagus. All right, so low baseline impedance together with elevated acid burden reflux episodes can predict response to anti-reflux therapy. So with that background, Dr. Vasey's group from Vanderbilt wanted to test if you evaluated baseline impedance using a catheter that goes through the instrument channel of an endoscope, that you can touch to the mucosa of the esophagus and get values of baseline impedance. And he did that at 3 levels and demonstrated that he could segregate non-GERD situations like endoscopy negative, pH negative patients, or patients with achalasia from patients who had reflux disease in terms of esophagitis, or endoscopy negative, pH positive patients. So in other words, the baseline impedance in the distal esophagus was lower in patients who had proven GERD, who had evidence of proven GERD. And the values were the lowest in patients who had inflammation up and down the esophagus, like EOE. They also demonstrated that it wasn't just EOE. Patients with other inflammatory conditions, like lichen planus, also demonstrated a low baseline impedance. So that was the first generation mucosal integrity tool that was developed about 10, 15 years ago. David Katzke's group from Mayo demonstrated that if you treated EOE, this is EOE data, if you treated EOE, you could see an increase in baseline impedance in the distal esophagus that would come close to what you saw in controls, and that you could differentiate GERD from EOE and non-GERD situations by looking at the pattern of decrease in impedance in the distal esophagus. In other words, if the decrease in impedance was throughout the esophagus, that was more likely to be EOE. If there was a gradient between the distal esophagus and the proximal esophagus, that was more likely to be reflux. And if it was normal throughout, that was likely a non-GERD situation. So with that understanding, the second generation mucosal impedance device was developed, and that was a balloon that has these impedance arrays. The original version had 4 arrays of impedance electrodes on 4 sides of the balloon that could be placed during sedated endoscopy and inflated so that the impedance electrodes had good contact with the mucosa of the esophagus. The second image shows the balloon in place in the esophagus. The third image is an endoscope looking through the balloon, and the gold you see on either side, those are the impedance arrays. So eventually, there were only 2 arrays. And with that, you could get those images that John just showed. So this was normal, a heat map of impedance throughout the esophagus. That's reflux. You see red, low impedance, and this was EOE. All right? And this was what I was trying to describe about the slope or the gradient of impedance. If you look at the green curve in the middle, you can see that it's low distally. So distal is towards the left, proximal is towards the right. You can see that there is a gradient. It's lowest in the distal esophagus, keeps going up. The top curve is normal, and the bottom blue curve is EOE. And this is a patient with functional heartburn. You can see that there is no red or green here, so the impedance is completely normal. The issue is this technology works better for EOE and no GERD than for GERD. If you look at these RSC curves, the red curve is GERD, the GERD curve. And so it is better at proving that somebody does not have reflux rather than demonstrating or diagnosing reflux. So these are some of the images. So this is a patient that we did at our center. You can see that it's mostly blue, which means there is very little area. There's a very little segment with low impedance. And I'll talk just a little bit about why that little bar, that little band of red might be there at the bottom. This is somebody with reflux disease. You can see red going about halfway up the esophagus. And this is eosinophilic esophagitis, red throughout, all right? So if you talk about mucosal integrity, MNBI of PPIs, low with damage, inversely correlates with acid exposure time, most useful when AET is inconclusive, and you can see some of the confounders at the bottom. Mucosal integrity on PPI, normal with healing, again, inversely correlates with AET, but if it remains low on PPI, it might mean that there is something else in the refluxate that you may not be able to fix with a PPI. Again, same confounders. Now, mucosal integrity balloon device, that's the device I just showed you, requires endoscopy. Normal values, at least the original studies suggested that that could rule out reflux. But the significance of low values was not as profound as it was initially believed. And that was thought to be related to the fact that there may be some residual fluid in the esophagus that might confound the recordings, but also the fact that the balloon could not be confirmed to be exactly where you placed, because the esophagus can shorten around the balloon can move while you're recording. So the other part about this mucosal integrity balloon device was it was very clunky. It was very hard, very firm. It has a particular texture to it that doesn't allow a smooth insertion. And you couldn't lubricate it because that would impact impedance. So there was some inherent issues with this. And so the third generation mucosal integrity, that's the esophageal endocap that John demonstrated. So this is a little cap that you slide onto the tip of the endoscope. It has these impedance electrodes at the distal end. There's another view. And here is a cartoon that shows how you place it. So you kind of just slip it onto the tip of the endoscope, and the top part is where the impedance array is. That's what it looks like placed on an endoscope. And that's what it looks like when you look down the esophagus. So this is the tip here. This tip is the part that does the recording. And you get images that look like this. This is the tower. So this is the new EndoCap device. I think they have examples upstairs if you go to the Versatech booth. And when you get your recordings, you can sequentially map out the distal esophagus. So you place the device in the distal esophagus, get your readings, then move up the esophagus. You can do it along one side of the esophagus. You can do it more than one side. So eventually you can get a similar kind of image as you would with the balloon. But here you are actually placing the recording right where you want it to be. So you're going to be above the squamocolumnar junction, you're going to be in the esophagus, and you're going to get information that is a composite eventually of what you've measured in the esophagus. Now let's look at some comparative data, because we did both balloon and endocap in a few patients. So this is one of our healthy controls. You can see that it looks all blue. So normal impedance, and this is the endocap data. Again, normal, right? So there were others where the balloon was probably placed too high in the esophagus. Here you can see just a little bit of yellow, but when we did the endocap and actually placed the device in the distal esophagus, we saw more red than blue. So this would have been somebody that we would think had low mucosal integrity based on the balloon device. Here is another example where the balloon device suggested lower impedance in the distal esophagus, but when we did the endocap, it looked normal. And this was probably a situation where the balloon was placed too low, because columnar mucosa, or Barrett's esophagus, can give you a low mucosal integrity, mucosal impedance value. So what are the questions that need to be answered? So this is new technology. Clearly, we don't have all the answers. What is the threshold using endocap? Does it match the MNBI threshold values? So what is the threshold above which values can be reliably normal or physiologic? What is the threshold below which values are reliably abnormal? Is there a gray area? There probably is. What is that gray area? If values are normal, how confident can you be that the patient does not have reflux disease? We don't know that yet. Do abnormally low MI values reliably predict a good outcome from anti-reflux therapy? If so, if you saw low values in somebody in whom you were not going to recommend surgery, you could just start out by treating them medically for reflux. And can management decisions be made using just the endocap MI values alone? We don't know that answer. So the aspirational investigation paradigm, my picture is not as pretty as John's picture, but would be the symptomatic esophageal patient with suspected reflux symptoms. And if you did an index endoscopy, again, we're bringing this to the endoscopy suite. And let's say we have all those answers that for the questions that I posed in the last picture. If you did mucosal integrity using the endocap and the values were abnormal or normal. If it was normal, if you were sure that a normal value equals a non-reflux mechanism of symptoms, you can move on and treat the patient symptomatically. If the values were abnormally low with a reflux-like pattern, then you would need to quantify reflux if you thought that further phenotyping would be needed. And if the values were equivocal, clearly you'd need to evaluate the patient further. So again, this is a technology with hope. It's like the gastro reject with hope. Technology with hope, right? But what we don't have is normative data. We don't know if MNBI data can be transferred to endocap, but this is something that we will probably have the answer to in a year or two. With that, thank you very much. Happy to answer questions.
We will start with questions. Rami?
Thank you. both of you. This is intriguing stuff and really exciting. I think I already mentioned to you, John, some of the problems that might occur is logistical regarding, the different departments and having to downgrade staff from one side to upgrade the other and that kind of thing. If you're going to downgrade your physiology unit to upgrade your endoscopy unit, and I think that is one of the major hurdles. But one of the things that I'm interested in here is all of these are testing objective measurements, but it's putting aside, this is both motility and reflux testing, it's putting aside symptoms. You're not trying to assess patients' symptoms to why they're there in the first place. If the patient says that they have reflux symptoms and we do the test sometimes, and acid exposure time is normal, but there's a positive reflux symptom association. This doesn't look into that. Similarly with motility, you're not reproducing the primary problem that they're presenting with, as in, if they have a solid, they might have dysphagia or whatever. You're just looking at the way the esophagus works in a secondary peristaltic mechanism. So we're removing the patient's symptom presentation from the way they're being tested. And I'm just wondering where you lie in this whole scheme of things.
So let me answer the reflux part first. So the way this would work, if it functioned like we expected, is that this would be in the hands of the index endoscopist, who's not a neurogastroenterologist. They are just trying to figure out, does this patient have reflux, or does this patient not have reflux, right? They're not trying to delve further into it. So if somebody has heartburn, your likelihood of that person having reflux is about 60, 70%. If they have acid regurgitation, it's about 70%, right? If they've taken a PPI and have not gotten better, the chance of that person having reflux is 30%. So if you can find the 60% that don't have true reflux based on mucosal integrity, bring them to the endo suite off PPI, and your mucosal integrity is normal, presuming that it functions like we think it will, or we want it to be, then you're not going to put them on a PPI, you're going to move on. You're not ignoring symptoms. They have heartburn. But if they don't have reflux, you're not going to put them through a PPI. If you're not sure, you're going to place some kind of reflux monitoring, probably a wireless pH monitor if they have typical symptoms, or do a pH impedance study if they have other types of symptoms. So no, you're not ignoring symptoms. You're just kind of shortening the interval to that initial question, does this person have reflux or not? Again, a lot of things have to happen. A lot of data has to be perfect for this.
Yeah, and I would say in terms of dysphagia, I think it's the exact opposite of what you said. Someone comes in with dysphagia, whether it's solid food, you take a good history, and if you perform a flip and they have racks and all of their dimensions, their distensibility plateau is normal, their EGJ is opening, they don't have a mechanical obstruction, they don't have achalasia. So you've ruled out the main pathology there, and you could very confidently assess them, and say, listen, you need cognitive behavioral therapy, neuromodulation. On the flip side of that, no pun intended, if you scope them and it's dilated and they have contents there, you're pretty sure they have achalasia. You could even make the case that maybe they don't need this if you have an AI platform, that can figure this out for people. But intuitively, we do a lot of manometries on people we know have achalasia. I mean, and getting a manometry catheter down someone with a dilated esophagus with food in there is very difficult. Whereas I could flip this thing down, no pun intended, and assess their EGA, show that it's tight, actually do a pneumatic dilation right then and there, and I have done that. Think about that. Someone comes in with dysphagia, they're having trouble, I scope them, they have a dilated esophagus, I drop the flip down, it's abnormal, I do a pneumatic dilation, study them afterwards, their DI is increased, and it's nice and beautiful, they're done. One day. Think about that. Think about how long these patients wait and suffer without knowing what their diagnosis is and sitting at home regurgitating while we wait for them to get a spot, in the endoscopy suite or the surgical suite.
That's just a small cohort of patients, the achalasics. We're talking about every...
Well, think about the normal ones. I just showed you that you can rule out most of those people and they don't have a mechanical obstruction. So you can do that pretty confidently.
Thank you for the lovely talks. Prakash, if I may, I have two questions, and maybe Daniel come up with some comments. Number one, is there any correlation or validation study with the equipment and in vitro biopsies, putting them into dosing chamber and look at the perfusion, permeability and electrophysiologic properties, number one. Number two, the study you mentioned about the normal values. When Daniel looked at the results, our normal values from Turkey was about 1,500 compared to the Far East Asia, 7,000. Same equipment. 1,500 versus 7,000. They were normal. I scoped them. How can you come up and think that those are the universal normals under the light of such findings?
I think everybody should move to Turkey. You
No,
have some magic.
should move to Far East Asia. They have 7,000. We have 1,400.
So it's very clear that there are ethnic differences between different groups. There is also difference based on different technology. So your equipment was different from some of the other equipment that was used. And so that is the reason, precise reason why we need normative values with the new technology. I do not know if it transfers over. I do not know if the MNBI value is the same as the endocap value. You know, that is the study that needs to be done. I forget your first question. Oh yeah. The chamber. That's been done. The lower impedance, lower resistance is associated with dilated intracellular space and some kind of injury to the esophagus. It doesn't need to be reflux. And sometimes when it's low, so when the values are low, you need to sort out the patient. So in my mind, this tool, especially if we have the capability of doing endocap, is only to identify normal from abnormal, and whatever your threshold is for that normal to abnormal. It's the normal people you're looking for, not the abnormal. If it's abnormal, you have to test them further to figure out why they're abnormal, whether that be biopsy or putting a Bravo or putting a pH impedance catheter. But if it's normal, if you can be confident that a normal test equals no mucosal injury from reflux, then you've eliminated the biggest cause for esophageal symptoms in the reflux side, on the heartburn side.
Yeah, I mean, I would just go as far as say, listen, I always look at these technologies, and I've spent a huge amount of my career focused on high-resolution manometry. I've spent a huge amount of my career validating Bravo and wireless capsule pH monitoring. But the fact of the matter is I think people tend to take this posture where people are wired to resist. This is a natural phenomenon. You bring a new technology, and people are automatically going to look for every negative. If they've never used it even, then they come up with these crazy thoughts that it's unsafe, that people are going to aspirate with a balloon in their esophagus. Ridiculous stuff that doesn't even make any sense. But the fact of the matter is I'm relatively optimistic here that this endocap now, because it's so easy to use, can give us this information that may make Bravo and these wireless capsules, as far as that first test, obsolete. And you know what? I'm fine with that. That's what I want to see. I want to see tests that are more comfortable for my patients, that work just as well and expedite the workup. And I think, it's sometimes in life you have to open your mind a little bit and accept. I mean, everybody, it's easy to be a contrarian. It's really easy to be a contrarian. It's much more difficult to be a disruptor, and you have to think about disrupting for your patient's comfort, safety, and accuracy of diagnosis. And we have to push the envelope. And I think these two technologies are the technologies that are doing that. And like I said, I've written countless papers on wireless capsule and HRM. If those mean nothing 10 years from now, but patients are getting an endoscopic evaluation while they're asleep and they're happy, I don't care. That's what I want to see.
Daniel, you have
John,
I think the biggest disruption is we, as esophagologists, will be taken out of the equation by AI. So you won't need our opinion anymore.
Can I make a short comment? And John, you said about yourself that you are a good clinician, and I'm sure that you are a good endoscopist, and on top of that, you are a connoisseur of all these new technologies, all in one person. How do you think that people in their own departments will be able to reproduce your extraordinary experience.
Well, I love the fact that you gave me all those compliments. I feel really warm and fuzzy up here, but no, I mean, I think, the fact of the matter is that whether you like it or not, AI is going to replace us. And I hate to say this here, but the fact of the matter is that, we know this already. We're designing platforms that are, 95% as accurate as us. And I do think that it's going to make things easier. We're going to pop these things down. The impedance signal is going to go up, and it's going to say, this is what the probability is of this. And it is going to make us a little bit obsolete. But, in the end, my goal is to not keep my job. My goal is to make my patients' lives better. And if I lose my job, you know what? I'm a pretty strong person. I can dig ditches. I can do whatever. I'll find another job. I'll become an internist again. I'll prescribe hypertensive medicines. But the fact of the matter is that, I think we are looking at technology replacing us.
But technology will never replace a dialogue between you and the patients.
Yeah,
and I agree with Rami that technology will not allow you to make diagnosis of hypersensitive esophagus, neither on functional heartburn, and you will not be able to talk with the patient more in detail about what the patient is suffering from. So I agree that the technology will help you, but I am not sure that will solve the patient's problems.
No, we'll become internists and psychiatrists.
Maybe.
And that's fine. I love talking to my patients about diaphragmatic breathing and, disorders of gut-brain interaction. So, I mean, that's fine. But as we see it as diagnosticians, it's inevitable. And sometimes in life, a good animal accepts what's happening and adapts to it. A bad animal doesn't and dies. So I'll survive and I'll let the machines, keep me as their pet.
Okay. One question.
Jenny Myers, Adelaide. Look, I think we've all been around for many changes in technology, discoveries of information, and I'm just sort of reflecting a bit like yourself, John. I've always wanted to see things become more automated, become more consistent. We've got a lot of consistency now, but there's also been waves of change, and I think we've all seen those waves of change. And when proton pump inhibitors came along, many of us saw our patient load would go down. And, I was told I'd be out of a job. And then when laparoscopic fundoplication came along, another suggestion was, we wouldn't have enough throughput, and I, again, would be out of a job. But, of course, that hasn't happened. But one of the things I think, some of these waves cost lots of money. And, like EndoFlip in Australia is not a billable code, so it's not going to be running anywhere time soon. And I remember, when the mucosal impedance stuff was coming out, when it was first tapped into, one of the quotes I remember from Jerry Maybury was that it will take 9 or 10 years before this gets to commercialization. And so now I'm sort of thinking with this AI wave and we've got multiple tools in our kit, but when is it going to be the norm? Because it's going to cost a lot of money before things can become the norm. And I agree with Daniel that we're not going to be removed from the equation, but hopefully, one of the dreams I had when I started in my career was by the time I retire, that there would be less work for me manually. It's coming, but it's not quite here. The AI wave will bring more of that, but it's going to cost lots of money.
No, and that's true. But, you have to look at it this way. When you have a motility lab, you need space, you need, people who are trained to do this, you need to spend time there, A lot of those things are eliminated with these new technologies too. But I will tell you that in thinking about, this whole concept of things making our lives better, and we've seen this. In 2011, I was here at this meeting, and the same people who are freaking out about losing HRM are the same people who were ripping apart HRM and saying this is not needed. Now you can't take it out of their hands. They can't, the HRM is, what are you doing? And it's the same thing.
It's just how we can embrace
Exactly.
Absolutely.
as a psychiatrist, not by training, but we are wired to resist. It is a clear amygdala reaction to everything.
Absolutely.
But the bottom line is that, this is going to happen. I will tell you, I'm pretty confident that there will be an AI endoscope that will basically be able to do what Flip does in 5 years, maybe 10 years, who knows? And maybe that'll complement Flip. It could replace Flip. And I'll tell you, if it does replace Flip, I want to be part of that process. That's the key.
It's just, it's going to cost us, and I think the question is, how can we embrace this technology? Because the financial cost is going to be
Yeah, it's going to swallow us up.
Yes.
Watch The Matrix.
Jen, you speak reality, but damn, I was, water pools at the bottom of our driveway. I was looking to hire John to dig a ditch.
I come from a long line of plumbers.
Yes.
But you're absolutely right. But you also have to remember that with every new technology comes a new challenge and a new set of patient-related issues that we need to solve. Something may be solved, but there'll be more unsolved or more confusion that it creates that will still be required. So, no, we won't be digging any ditches anytime soon. Maybe kickboxing.
Okay. If there are no more questions, I just have a few comments. So, Prakash, you did mention that the endocap was good at ruling out reflux. Maybe in future it will rule in reflux. It will also rule in EOE. That means 2 of our technologies get thrown out of the window. That's esophageal biopsy as well as pH metry.
Yeah, the problem is, what you have to think is, based on what the endocap shows, are you going to send somebody for fundoplication? Are you going to not take a biopsy? Are you going to give somebody steroids or a biologic that costs $80,000 a year based on what the mucosal impedance, mucosal cap shows? Right now, the answer is no. Okay. But if that were normal, if you got a blue out, I would be comfortable sending that patient for cognitive and behavioral therapy and not giving them a PPI. So that is what I think is low-hanging fruit, not the other way around.
Okay. And same for John. I think you already said that after you did the flip, very few of your patients were going to go to HRM.
Not very few. I think, if you looked at that algorithm, if you're normal, probably not, most likely not. And if you have achalasia, which is the rarity, but once again, I see a lot of people with achalasia, so it's a little bit more in my practice. But in a general practice, it's going to be less than 10% there. So there is still a role. I mean, HRM is not going away. I still think it's the best tool to evaluate belching and regurgitation. I prefer that actually with a postprandial meal, where I can actually look at what's happening and see the mechanism of either rumination or supragastric belching as a better way to approach that than even doing 24-hour pH impedance. I may actually not have to do 24-hour pH impedance because my text says this patient's ruminating, and I tell them, all right, don't do that, and I'll come down and we'll do diaphragmatic breathing. So I think, the manometry is still going to have a place. It's just going to be shifted a little bit.
Yep. So thank you for letting us keep our manometry and pH metries.
Not for long.
And thank you all for wonderful questions. Thank you, Daniel.
Thank you.